one take. There we go. All right. When most people think about physical therapy, they picture injury, something that happens after the damage is done. But for Josh Kidd, physical therapy lives much earlier in the story. Josh works with people whose jobs leave very little room for error. Fighter pilots, special operations personnel, where recovery and performance and decision-making all have real consequences. He's also shaping the next generation of clinicians as a faculty member, researcher, and residency director. Lately, his work is focusing on a concept that sounds simple, but carries big implications. Directional preference, how the body responds to movement, and what that response can tell us about healing, readiness, and performance. Today, we're talking with Josh about what directional preference really is, why it matters beyond the spine, and what the current evidence reveals, not just about treatment, but about how clinicians think. So let's get Josh Kidd in the studio. Josh, welcome to your episode.
Hey, thanks. It's a pleasure to be here, guys.
I mean, setting the bar pretty high. That sounded pretty cool in the intro, right? Let's go back first. How'd you get to do all that stuff? And we'll get to the stuff, but what was sort of the 30-second career arc to get to where you are now?
Yeah, it's funny. I think you really overhyped the bio, so I appreciate that. No, it's funny, like most PTs, I started off and wanted to go into orthopedics, right? I wanted board certifications, started to go that route just as a basic clinician, right? In a normal outpatient orthopedic practice, had the opportunity to buy in, become an owner in that practice. So started to grow in that realm. And I'm like, man, I love outpatient. I want to continue to foster this. We're bringing in a residency program, bringing in mentors in residence and enjoying my time. And then these funny things called third-party administrators started to come around, right?
Uh-oh.
And then my administrative burden started to scale. And I'm like, I don't know how I feel about this so much. And so I decided, hey, I'm going to get out of this. And my thought was go cash pay. I'm like, I want to go cash pay. I want to set my fees. I want to treat patients. I want to treat them. And so sold my practice and was doing that route. And I got a phone call from a good colleague of mine I knew he was doing something with the military, but I didn't really know what it was. I thought he was just hanging out and chatting with a few guys. And he calls me up and says, hey, I work with the military. My company's growing. I need quality assurance. I know you run residency programs. I know you have a solid foundation, and I want to practice I want all of our guys to practice the way you do. And he says, and I said, okay. And he goes, but I know that you're busy. He didn't know I sold my practice. He goes, I know that you're occupied with your business. So do you know anybody that could do this? And I said, well, actually I do. And he said, who's that? I said, it's me. You know what he did? He hung up on me. He goes, I got to call you back. And it was so funny. I get home, I talk to my wife, and we're doing this cash pay transition thing. And I said, hey, I got a call from Randy today, and she goes, what do you want? I said, well, he pitched me a job to work for his company. And she said, well, what'd you say? And I said, I told him I was interested. What'd he do? I said, he totally hung up on me. And I didn't get it either, right? So he calls me 2 days later, and he says, hey, man, he goes, I'm sorry, I just couldn't process all that. He goes, I was looking for one thing, and then when I found out it was you, I had just total this big gamut of things I want to do. He's like, I want you to come work for us, and I want you to run this thing. And so, it just kind of happened by happenstance, right? How I fell into it. And I would say it's probably the coolest job in the world, man. I mean, the population we get to serve is amazing. Our teams are usually set up what's called an HPO team, so a human performance optimization team. And foundationally, it's usually about 5 different types of providers. So there's a PT, there's an athletic trainer, there's a strength coach, there's a sports psychologist, and there's a nutritionist. And we're basically embedded within a special operations unit. And our job where I'm at is to take care of 64 special ops guys. And we get all the toys and we get all the time. So I don't have to bill anything. I got a guy right now, he's got a quad tendon repair, and I'm with him for like 3 hours a day, man.
Wow. So
the ability to practice at the top of our license, it's been pretty special, and it's been rewarding, man. And again, I don't have to deal with those pesky third-party administrators anymore. So that's been the original shift into kind of the human performance realm. And it's been
That's
great.
Fantastic. All right, good. We've got context, but now let's drill into, for the clinicians out there, let's drill into this. You're working with special operations, fighter pilots. We sort of set the stage there. Yeah. These people do not have time for guesswork. The first time someone ever framed, when I was a PT student with this podcast, his name was Rich Westrick. Rich said, listen, if you train triathletes, when the race is, what time of day, likely what the weather's going to be, the exact course. He goes, people don't have that in operations. You don't know when the bell's going to ring, right? So these people do not have guesswork. Where did directional preference become something so central to your clinical thinking? How'd that happen?
Yeah, it's how we came into the unit. So I sat down with the commander basically day one, and I said, okay, where can we have the biggest change? And he broke it down, and they track everything. Every metric
Sure.
is tracked on these guys, right? And they said, hey, believe it or not, my biggest problem is back pain, neck pain, right? And so my background, I'm the director of the McKenzie Institute's residency program. So that's kind of the Kool-Aid, a little bit of the Kool-Aid I'm drinking for preference here. And so I said, okay, we have a specific way we can target this. And I said, let's just start tracking. Let's look at metrics. Let's see if we can change the prevalence here. And so based on what the unit leadership wanted, we said, okay, let's go after spine pain, because that was, similar to outpatient. Everybody thinks it's going to be all different. It's spine pain. And a lot of times it's when they're not doing their training and doing their missions, right? They're not really getting hurt out there too much. It's more when they're back home and they're more sedentary and less active. And so we started to look at the data, and we said, okay, let's utilize directional preference as an avenue to assess, but then also determine prognosis. And we've actually been collecting some pretty cool data on it, which I'm happy to share with you as we move forward here. But that's really what set the stage. Sit down with the commander. He says, I got a problem with spine related issues. We've had high level therapists in here before taking this approach. I said, well, let's try something different here and see what we can do. And, we've got 4 years now of training data, and it's actually trending in a pretty good direction.
What's that commander's background, just briefly? Is it a healthcare background or not?
No, man. The
reason I ask is it sounds pretty damn informed.
Yeah. Well, his job is to take care of those guys. And so he works side by side with the HBO team. He's worked side by side with the flight docs, right? And in flight medicine. And so he needs to keep status on who's green lighted and who's red lighted on his teams, because he'll have to move pieces around.
Sure.
If one guy's not operational, he's going to have to swap somebody into that unit, because everybody has a significant role within the unit, right? And so it's his job. It's his job to stay on top of it. And the crazy part is he actually has overall say of if this guy gets to go or not, right?
Wow.
And with no medical background, it was fascinating to me. But yeah, that's his job to make sure he's on top of every one of those guys, both from a physical, mental, family style, operational style, across the gamut on each one of these guys. He basically has a profile on. Yeah.
All right. You mentioned Kool-Aid. Let's talk about some Kool-Aid and different flavors, right? We'll get a little bit into the Kool-Aid. For someone who's heard the term, but maybe never fully got it, or maybe they need to hear it from you one more time. How do you define directional preference?
Yeah. So directional preference, I look at it, a lot of people will look at it as, an exercise, and we look at it as assessment. So for us, what we want to be able to do is when you look at it at the basic foundation, it's directional preference is a specific movement. You can move any joint. Most of the research is on the lumbar spine, some on the cervical spine, but a specific direction you can repeatedly move a joint to in range in which you will see two things happen. You'll see an improvement in pain, and you'll see an improvement in mechanics or function. So range of motion, strength, their ability to do something that was previously painful, and now that pain is resolved. But that movement that improvement has to last, right? And so it's not, hey, I can move you around a little bit and get some exercise induced hypoalgesia, and you're going to feel better, right? Exercise induced hypoalgesia. It's not just that, right? It's not just, hey, I move a little bit, I feel better. It's moving you in a specific direction that makes you feel better. And a lot of that's ascertained from the history in the exam. Yeah.
So now let's go the opposite. Now that we know what it is, what are some of the most common misconceptions clinicians have about it? What are the things that Josh is most of the time correcting and saying, well, actually not that, it's actually more like this?
Yeah, no, the big thing, I think a lot of people think it's, for some things to be, and this is where the limits, some of the nuances we can talk about the research we've looked at, because there is some discrepancies about the definition of it. And that's what we aim to try to clear up with some of our stuff we were looking at. But, a lot of people think, hey, if I move in one direction, it makes them feel better. I got to move them in the opposite direction, and it's got to make them worse. And you don't always see that. And sometimes that's with specific patient demographics, you will and you won't see that. So that's necessarily not always the key. And then there has to be a lasting change, right? For example, I have low back pain, right? I'm a general person. I have low back pain. What do I normally like to do? Right? If my back's hurting, I want to lay down. I want to put some pillows under my knees. I want to get a recumbent position. I'm going to feel pretty good, right? Is that directional preference? And I say no, because what happens once you come out of that position, you stand back up, what happens? Pain comes right back. Right. So there has to be some lasting change and carryover. And what you should see is you should see this gradual progression to improvement. As I continue to do more of the movement, I get better and better and better. Not, hey, it feels good when I do it, and then it kind of comes back, so I kind of got to do it again, and then it feels better. But you go through this repetitive cycle. That's not it, right? So it's got to be lasting, and it's got to be sequentially improving.
Yeah. You're jumping into some research with some pretty big names, right? Part of a recent scoping review in physical therapy. What question were you trying to answer, and how that what answer did we get?
Yeah, that's a good, I think like similar to most scoping reviews, I think you're going to find out. So we were when you look at the clinical practice guidelines and you look at systematic reviews around directional preference, it's all over the board. Some systematic reviews say, hey, this is beneficial. Others say, no, it's not. Some say, hey, this is good for chronic pain, maybe acute. Some say, no, it's not good for anything. And so our aim was to look at, when you look at previous scoping reviews, they looked at your level of training and being able to identify it, right? Is this generalizable, or do you have to go so far down this rabbit hole that it's not even going to be beneficial to do that? And so we just want to look at the definition. We want to say, okay, maybe it's not the level of training, maybe it's how people are defining it. So what we did was a large scoping review, and we looked at all the research that used the word directional preference. And we want to know, how'd you define it? Like, what was you, if you're saying, hey, it has no effect, or hey, it has this amazing effect. Okay, how did you define it to determine what it was and what you're doing? And we found out, there was a mishmash. We started off with 15,000 studies, right? Broke it down, and we went into full review on 149 studies. And of those 149, we found that there was 115 different definitions.
That does
it was all over the board. And 22% of them didn't even have a definition. They said, we do directional preference, but we're not going to tell you what it is, right?
Wow.
Which we found intriguing, right? So what does that mean? I think it means that we need to look at what is a more concise definition. And I think there's different ways to go about looking at that to determine, okay, how do we accurately define this? And then how does that definition translate into clinical practice, but also research? And I think, we see this all over the board. I know there are similar studies that have been done looking at what is manual therapy, right? Because that's still some of these things that's ill-defined, right? And so we've tried to follow along those same lines. So hopefully if we can get a more uniform definition, then we can research it, but then we can also use it as a clinical tool more appropriately. Yeah.
You almost maybe half already answered my next question, but I got it queued up, so I'm just going to answer it anyway. How do those inconsistencies in research you were just talking about, how do they show up? What do they look like in everyday practice? If we don't even know if we're not even agreeing on terms here, we're not going on the same dictionary. So I'm using a word one way or a term one way and you're using another. How does that show up in practice then?
Yeah. I think it can cause people to potentially abandon it early and say, hey,
sure.
There,
Yeah.
Right. We looked at some of the studies, when you look at, let's just say the treatment-based classification systems, right? They have different subgroups, right? We have this manipulation subgroup, we have the stabilization subgroup that are based on some clinical prediction rules. And then we have this exercise-specific group, right? Which is essentially based on directional preference. Well, in their study, what they would do is they would say, okay, if you had pain down your leg, you do 10 forward bends, 10 back bends. And if it didn't change the symptoms, boom, you're out of there, right? We looked at other studies and we're like, no, we did that. But then we lay the person down. We would do that, that prone press up that everybody is synonymous with, like McKenzie, but then they would be moving the hips and doing these gapping techniques and all these different movements, and they were finding a higher prevalence, right? So the question is like, okay, we're not even doing this the same. And so if you look at one of these studies and say, okay, I'm going to bend them forward 10 times and back 10 times, if that's the only one study you read, you're probably going to abandon things a little early. Versus you read that other review and it says, hey, no, wait, there's so many different movements that I need to employ before I can move on from, hey, this isn't going to exhibit directional preference, right? And how it's defined also, we saw some variability in the clinical practice guidelines, right? And for the low back pain, we looked at the first one, the guidelines that came out, and directional preference had this A-level evidence, right? And then when you looked at the revision, it had this B-level evidence, right? So we broke down those studies that they looked at, and we found varying themes within those definitions as well, right? So we basically identified a few specific themes that must be present. And if based on the research, and then also based on this thematic analysis we did in addition to our scoping review. And so depending on where you're looking and how they're defining, it's going to clinically going to drive what you do or how quickly or don't quickly you abandon it.
Yeah. So how does this approach, how does directional preference, let's bring sort of both of the things that you do together, the research, directional preference, and working with athletes or, tactical athletes, tactical operators. What does this approach offer when time matters? You just said operationally, this is money, this is effectiveness, this is readiness. What does that approach offer when time matters with those types of people you're working with?
Yeah, let's put some context around that. So within the unit, for our guys, depending on what level of training they have, it's going to cost between 1.2 to about $1.9 million to make one of these guys, right? Wow. The government has it down to a dollar figure, and it's $4,328 and some odd cents per day that these guys aren't operational. Okay, so they track this, right? And they look at these
the cost of not being ready.
Yeah, and they know. And so there's huge incentive to get these guys back to duty quickly. And every one of these guys has to, no matter what service you're in, they have to be able to pass some sort of operator fitness test, right? And every branch is a little bit different to be on status, to be operational. And so if they can't pass that due to pain, due to whatnot, they don't get to go, right? And then they start costing money for the government. And so the intent for us was like, okay, how do we get these guys back, right? Now, when you look at, it's basically sport-specific PT, we have this whole battery of tests we can use for a lower extremity injury, right? Like I hurt my knee, I can look at hop testing, I can look at Y balance, I can look at all these different metrics, say, okay, you're ready to go. Okay, you've passed this, let's put you in the test, let's make sure you're set. Same with the upper extremity, right? But the question is, like, they already told us our biggest problem is spine-related issues. What return to sport testing is there for spine-related issues, right? Nothing, right? And so what we started to do is, okay, let's see if we can use directional preference as a performance metric to get them back. Because what we were doing is we were defaulting back to more of this traditional pathway anatomical diagnosis. They come in, we say, hey, you got a grade 2, you got a grade 1 or 2 lumbar strain. You're going to be shut down in about 3 weeks to 6 weeks, depending on the severity of it, right? Well, now what we've done is just, okay, let's put you through our exam, right? We do a basic AAOMPT exam, looks nothing different than anybody AAOM's going to do. And then we throw in this repeated movement testing with it. And if they exhibit directional preference, we actually use that as their guideline to if they're ready to return back to duty, right? And so we know that, like we said, directional preference is moving them in a specific direction that reduces pain, that decreases their pain, and improves their function. So what we've done is we've basically broken down component movements of their fitness test that they have to pass. And once they come in, if they exhibit directional preference, we get the pain resolved, we get the mechanics restored. We then go test specific parts of that test. And if they pass that without a reproduction of pain or a loss in function, we greenlight them. And we've been tracking the data now for 4 years, and we're getting our guys back to duty about 36% faster than we were 4 years ago. Yeah. I mean, it's upwards of, 18 to 22 days, right? So you can times that by that number, right? So, and that's the intent, because these programs cost the government a lot of money. So it's like, okay, how do we incentivize to keep these programs, because they're so valuable, but they have to demonstrate some sort of value, right?
Now I'm going to make you think and answer bigger, no pressure. But if the profession did a better job leveraging directional preference, what could change? That was my question that was queued up a minute ago, but you're putting numbers to this. You're like, well, if these guys are $4,000 a day, it might be smaller if you're just a podcast host, right? But to me, that's a lot. So what would you imagine, or how would you explain it to a student if the profession did a better job leveraging this? Man, what would that look like?
Yeah, I mean, I guess I'll say the caveat, right? So I a little bit of bias here, right? Because I teach for the Institute.
You mentioned the Kool-Aid.
So
okay.
I'm going to put that out there. But, I think, like I tell all my students, I say, this method works for me because it makes sense in my head. Doesn't mean you need to do this method. Whatever framework works for you that you want to employ with your patients, that you can, that's evidence-based, do it. All I encourage people to do is, just put in repeated movements and identify, if you can, look for directional preference based on these criteria. Because if you do, a patient's going to get better. When you look at, you look at the guidelines, it's still A to B level evidence. So there's a high level of evidence for this, right? Nice part about it is a lot of it, the patient is able to do independently on their own, right? And so you're starting to build this self-efficacy for the patient. You're starting to empower the patient, right? To be able to treat themselves. So we're looking at decreasing, more chronic related problems. We're going to look at decreasing recidivism of problems because they're self-managing it, right? The cool part about the system too is, it's this cause and effect check, recheck system, right? Patient tries to bend forward and they got pain shooting down their leg. They do repeated movements. All of a sudden they bend forward. Hey, it's not down my leg anymore. You think the patient's happy or not, right? They can feel an immediate change, and you don't have to create much buy-in for that, right? And so, one, the ability to, like we're demonstrating, to accelerate recovery, but two, to empower the patient to decrease recidivism. So we're looking at decreasing overall healthcare costs. We're looking at decreasing overall chronicity of problems and more downstream related issues that we know are so associated with that. So I think there's power in it, right? And like I tell everybody, I'm like, just put it in, you do you, but just throw it in your exam, man, and you will start to see change, right? And then you just see where that fits within your own treatment system.
If you could leave clinicians, we'll do we call it the wow, your words of wisdom. If you could leave clinicians with one shift in how they think, not just what they do, as much Kool-Aid as you want in this answer. That's allowed. After listening to this episode, what would it be? What would one shift in how they think that you would suggest, not just in what they do, but how they process?
I think the biggest thing, and I try to do this all the time, is be open-minded, right? Understand that one thing doesn't fix everything, right? If there was one thing to fix everything, we'd all be doing the same thing.
Sure.
There's all these different things out there, right? But we tend to be closed off and have our own confirmation and internal biases, right? Hey, I did all this training, so I'm going to do this, right? Be open-minded. Try other things, that hopefully have some level of evidence behind them. Fit them in your system, because, there's value in what I do, but I take so much from everybody else as well. I'm like, okay, how does this fit in? Oh my gosh, this was the last little piece I needed to help this patient population that I've struggled with. So, my biggest thing is, obviously I'm biased. I'd say take a course, try it out, but be open-minded about it. Don't just throw it out because, hey, I did a couple of these things. I tried it once, it didn't work. Yeah. Understand a little bit more. Understand it's more complex than what people might think. It's not just simple, straightforward forward bends or backward bends, and explore it a bit more, right? Because you will see change.
What would some of those things that you've tested and tried and taken some things from? This is where you can throw out just names of courses. We're not saying you're endorsing them, but what are the things that you've tried that you're like, hey, I've tried these. These are the different flavors of Kool-Aid I've drank.
Yeah, well, the nice part about the government is they like to spin us up on everything. So if there's something out there, I've been through BFR, I've been through dry needling, I'm a strong first kettlebell instructor. I went through my USAW certs, my fellowship had a Maitland and Sourman flavor to it, right? So I do look at some MSI stuff. I did take, I have a master's in orthopedic manual therapy that was more osteopathic based, right? So there's all kinds of stuff out there, and that's why I know this other stuff works, right? But sometimes, I know prior to, I was probably, before going through a lot of that training and being around these other highly skilled clinicians, I was a little closed offish, and I would just shut other things down, be like, nah, that's not right. But there is such an application. I think the more and more you get better at your craft, the more you recognize, hey, these other things do work. It's like every time I go to AAOMPT, man, I'm learning so much from all these other people, right? And I'm like, okay, I can definitely see where that fits within my system and why that would work. Yeah. But then at the end of the day, I think if we're just nice to our patients, a lot will get better too. So,
we need a course on how to do that. Josh, you're going to lead that course on how to be nice to our patients. This is one of the reasons you just highlighted without me having to ask. Why do we sit down with microphones and put these things on YouTube and share them and let them, this is outside of membership as well, as this is show more than tell what the value of membership is. You're looking at a snapshot of Josh here, but someone like Josh goes to AAOMPT as a member because they understand the value in those things. And those things are intangible. I try to make this as tangible as a podcast or a video could be, make it as tangible as you can, because that's where the value, in my opinion, really is.
Right.
Awesome. Well, hey, Josh, appreciate the time. Hurry up, get back to work. You're costing the government some money. Get some people back faster. And we appreciate your time here on Hands On, Heads Off.
Hey, thank you so much. It was a pleasure to be here.